Right. Terrific. Well, thank you. Thank you all for your attention and your interest today. I'm Rachel Richesson from the Department of Learning Health Sciences. I am not a programmer or developer, as I think many in this audience are, but I've been working with data standards and informatics for a number of years, and have been watching the evolution of FHIR, and seeing its potential becoming realized now. So I'm happy to share sort of my take and experience with this, and then have some time afterwards for questions. Just to be sure, we run till 1:30. Is that right, Gabriel? About an hour. Okay, I will end before that. Okay, so some will. Hi, Gil, it's good to see you. Good to see you again. Okay, so I'll just jump in, and I am happy for people to throw questions in the chat or interrupt me if anything is not clear. Let's see. Okay. Am I on my outline yet? Okay, so I thought I'd just give an intro of FHIR and why it's relevant to MDEN. And actually, before I start, if anyone could just raise your hand if you are already familiar with or use the FHIR standard. You don't have to be an expert user, but I'm just curious if anyone online has used it. Aaron, okay, a little. Or a hesitant wave. Okay, this is just helpful for me to sort of gauge the audience a bit. Hopefully this won't be too foundational or too technical either for the range of folks here. But I'll talk a little bit about the origins and history, then the specification itself and just some key features about it. But then I really want to talk about the community around FHIR and standards development in general, and where I think there might be some value in engaging there. And then we can talk about some possible next steps for MDEN and have some questions and answers. And then I have a whole bunch of resources for future learning that I'll recommend. And we don't necessarily have to get through them all, but they'll be a part of the slide set. So first, what is FHIR? I'm assuming everyone's heard of it, but maybe people are not as familiar with the acronym. So FHIR is for Fast Healthcare Interoperability Resources, and it's a data exchange standard. So it's not a data capture standard, and it's not a content representation standard per se. It's really a way to exchange data between two or more systems. And it describes the sort of the data formats, the components, which are resources, and an API interface for exchanging health information. I do want to point out that FHIR is maintained by the Health Level 7 organization, which is a non-profit ANSI accredited standards developing organization, or SDO, that's dedicated to provide comprehensive framework and related standards for the exchange of electronic health information, sort of broadly defined. So definitely like electronic health records, but also other sources and destinations for that information. So it's very broad, and it's been around since 1987. And so I'll just point you to HL7, to the website, to sort of engage with the community, and I'll hit some highlights for you as well, and hopefully you'll be motivated to hit those web pages at the end of the talk. FHIR, in a nutshell, represents data as resources that are standardized and reusable. I'll show you a few of these now. FHIR supports common exchange methods, particularly REST, as well as messaging, documents, and services. FHIR supports a spectrum of integration from within and outside of institution, and it's enabling existing use cases and really provides a standard and a platform for future innovation. That is the goal, and that's driving such excitement. I'm going to ask if people had heard. I think most people, even though a lot of people weren't familiar with it, I'm going to assume a lot of people have heard about it, particularly in this group, just because there is so much excitement and uptake from this. So how is this relevant to MDEN? I really, in a very, very broad way, think of FHIR as an exchange standard to sort of read data from EHRs and potentially write data to EHR systems. And this can be used to support many patient-facing apps, as well as provider-facing apps, and even back-end systems that can use the FHIR APIs to access data from the EHR system. And what's particularly exciting about FHIR is just how it has become embedded in regulations now. So first, through 21st Century Cures Act in 2016, the Office of the National Coordinator, whose name has changed now to the Assistant Secretary for Technology and Policy. I don't know if folks are familiar with that change that just happened within the last month or so, and HIT.gov still works, and the ONC title sort of still exists, but the department has moved to the Department of Health and Human Services and really been sort of elevated with this move. Nonetheless, that group has for a number of years and continues to promote the adoption of FHIR as part of the EHR certification program. The 21st Century Cures Act is also noted information blocking and is developing solutions and penalties for organizations that are not sharing data through this FHIR API. And the excitement and adoption is also being fueled by CMS and other incentive and payment and penalty programs for providers and hospitals, and as well as patient access for insurance providers. So this idea of FHIR as a standard that can be used to fuel innovation and also develop scalable solutions, I think is quickly becoming apparent. Just a few words about the history of FHIR and in the history of HL7, sort of where the void that FHIR has come to fill. I mentioned HL7 began in 1987 and almost immediately began working on a standard that looks similar to what is on the left. I don't know how many people are familiar with HL7 version 2. It is still in use because it was a very successful standard in terms of knowing exactly what place in sort of a data transmission field certain variables will be. It would handle certain data headers, and it was a very predictable scenario, but allowed for organizations to create individual segments and add-ons and basically tag on information in a non-standardized way. And so this sort of the old joke with HL7 version 2 is that if you've seen one HL7 implementation, you've seen one HL7 version 2 implementation. And so it really didn't sort of get the scalability or enable true interoperability. It was sort of point to point where different organizations really had to agree on sort of what information was going to be placed where beyond sort of the base spec, which was used for part but not all of the information that was being transmitted. So probably around, gosh, like maybe 2000, version 3 started to come about, and version 3 had it's encoded in XML, as you can see here, but it really tried to incorporate good software design principles and some foundational modeling, like the HL7 reference information model, and just sort of a high level conceptual relationships through this conceptual model that would sort of the intent is that would carry on to all implementations of version 3, and that different groups then could develop their own domain implementation model. So public health, for example, or clinical research or laboratory information management, people could develop their own domain analysis models and software projects, sort of all referencing this broad model. And this became a challenge, and many considered it as sort of a failure, because although version 3 attempted to address the sort of lack of consistency that we saw with version 2, it added a level of complexity and abstraction and really just communications and delay that just made the development of applications using this standard to be quite lengthy in process. And although there was this ability to develop conformance testing modules, it really added to the length of it. So there were probably about 10 years that HL7 version 3 was really being heavily promoted and used, but the developers and implementers were saying, this is too complicated, this is too confusing, we're just not sure how to make this work. And so around 2010, HL7, the organization, created a fresh look task force that just said, how can we, should we be looking at modern exchange technologies? Let's just divorce ourselves of all prior versions and think about what would make sense for interoperability and exchange of data across systems. And so out of that, soon after, there was a proposal by Graham Grieve, who is an informaticist and really on sort of the bioinformatics side in Australia, and he promoted these fast health interoperability resources. I think it had a slightly different name then. If you're interested, you can actually hear his take of the story and how this was, but he was surprised and really elated, I think, that the HL7 organization just said, yeah, let's just stop what we've been doing for the last 20 plus years and really adopt something new. And so the spirit of FHIR really came with this this understanding and an entire paradigm shift that, this standard, instead of being developed sort of from the top down by domain experts and professional and, expert sort of knowledge engineers and software programmers, that this would really just focus on implementers and be simple to learn, simple, easy to access, open source, very available and usable. And so this manifesto, I've got sort of the link, you could sort of look in more detail. But the key is that it was focused on implementers and really using the latest web technology. So it was really a reinvention of HL7 standards that were known to date. There's a number of blogs that sort of tell the story. This blog here by the motorcycle guy, Keith Boone, gives a little bit of the history as well. So if you're interested, there's lots and lots of extra reading. Regards, just fast forward, and I think many people are aware that FHIR has really gotten out an endorsement in regulations. The 21st Century Cures Act sort of baked this into the certification process, created resources for the ONC to develop certification criteria and conformance testing, working on information blocking, and sort of a scaled approach to let EHR developers use different draft standards of FHIR while it's being developed into a normative standard, so that we could get real world use sooner. So you can certainly check the details of those timelines. But what we have now is FHIR is really a part of the US Core, the US Core Data for Interoperability, which is a standard set of health data classes and data elements for nationwide interoperable health information exchange. And what USCDI is, it's really a transparent, predictable, and collaborative approach to like evolving standards and naming standards as the FHIR spec and implementation experience evolves. So the first Cures Act final rule designated US Core, USCDI version 1. And then over time, that has been evolving. This is just a quick snapshot of version 2 added a few more data classes and began to address social determinants of health. Version 3 added 24 data elements. This is all a very public, open, consensus-based process. So through these links, you can see how you can actually see where the latest, I think it's version 6 that's under development now. There's an opportunity for people to comment publicly and sort of see where things are going. And so the current version right now is US Core version 5. With that said, I really wanted to point out that the adoption of these is still years in advance. So US version 3 is sort of the current codified standard, and that is not mandatory for new systems until 2026. So there's a bit of a lag of what you see first from the FHIR spec, then from the US Core as to what you will actually see in different implementations. And just another view, and you could go directly to the US Core page and you can see how things have evolved over time and where we are now with version 5. But again, I'll mention that version 3 is effective in 2026, and the effective date for version 4 is 2028. So we've got really a bit of a lag. Here's an overview of the US Core elements. And so these are represented in FHIR with terminology, but you can sort of get a snapshot of what is sort of our national core set of common data elements, if you will, things that we will be able to soon expect all EHRs to deliver. And then just a further note for researchers in the audience, the NIH several years ago really saw this momentum and really put out just sort of a notice to all programs and investigators to really look at this standard and consider ways that they could leverage it for efficiencies in research and connections with EHR data. I'm just checking if someone wants to put something in the chat, just give me a little shout out if there's something there. Let's see. Oh, okay. Just Thanksgiving talk. Okay. So now maybe I'll just go over a little bit of the major features just to give you a sense of it. And then we'll move to the community and then some more discussion. Okay. So features at a high level, I'll just broadly introduce you to some modules of how to see it. I mean, this is really something you can quickly get your hands on and look at whether you're a developer, a programmer or not. The API REST principles, and then, so the resources. So I will quickly go over some of these. Okay, so getting started with FHIR. I mean, the best way to get started with FHIR is really to go to build.fhir.org and check out these modules. So in order to help implementers access it, there are so much support, and it's highly organized and hyperlinked. So if you just start playing around with the spec and search for what interests you and what you need more information on, you will just continuously be given the information that I think is relevant. I mean, it's really well organized. There's a number of my oh, go ahead.
Rachel, can I ask a high level question?
Yeah.
As an approach?
Yeah, absolutely.
Would most scenarios be a project specific adoption of FHIR standard for these, let's say, 4 data tables for this cohort, and I'm going to, use it? Or would it be an institution doing an all over adoption of this standard for all, let's say, clinical data, all EMR data? Is it project specific, do you think, or should it be done at an institutional level?
Yeah, that is such a great question. And I think right now, I mean, I guess I would say ideally I'd love to see it at a institution level, because then you could imagine, okay, anything that's in FHIR, theoretically, we could build whatever we can imagine, right?
Right.
But yeah, it's never a data capture state. I mean, it's always something we're mapping to, and it is a huge expense and lift to do. So I guess with that said, Erin, I would say there's probably a middle ground that it would be great if this and other talks could stimulate like a small group of people that would say, these are the primary things we need.
Starters. Yeah. Okay. That's a good way to think about it.
Yeah. And I think, though, you're right about it probably is project by project, but where someone has this really specific app or application in mind.
Yes.
And then you could look, and there's probably a handful of resources that are really important. And those are probably the ones that are part of the certification criteria. But I guess I'll just say, in general, if we got folks together to sort of identify maybe the lesser known things, some of the things around provenance and sort of the traceability data, that would support like a whole lot of researchers trying to get data and really understand the context or the provenance, the traceability of that could support a lot of like drug kind of studies. And with the mobile health group, I wonder if there's probably a handful of things that they would say, this is really important to start thinking about and prioritize.
Yeah, I totally agree. Thank you so much.
Yeah, thank you. Yeah, thanks, Erin. I appreciate it. And others, please do jump in. And I'm happy to talk further or send other resources afterwards. So again, getting started, I think these modules, you can just kind of look at the foundations. Terminology is huge, and I hope I could sort of make that give you a sense of that picture as we sort of navigate a little bit around some of the standard. We're defining these data classes, but at the end of the day, are we using the code systems here, and are we using them consistently so that we have data that is explicit and that is comparable and consistent, I guess, within an organization? And if we still have those challenges, which I think every organization does, FHIR can't help us with sort of understanding, what's going on in terms of data collection or data quality. So I just want to point that out. And terminology, I think, and some of the binding of FHIR classes to terminology is really important. But you can get sort of an overview here really quickly on this, just getting started with FHIR set of modules. So the standard is really laid out in a modular fashion, and there's code things that are sort of in computable formats for the resources, which I'll show in a minute, but lots of human readable stuff, which I think is really important. FHIR uses RESTful API principles, and in particular really focuses on create, read, update, and delete functions. And as a REST principle, it's really about separating the data from the user application and interface. So I think this may be familiar to a lot of folks, but this was really quite a paradigm shift from sort of previous data collection and approaches to standards. As a RESTful specification, FHIR is really organized around the concept of a repository of resources. And then these resources can be combined to sort of collect and use the data that's of most interest to a particular application. I won't go into a lot of detail on this, but I'll probably say, at least a few times about the idea that it's extensible. So FHIR is almost the basic building blocks of data classes, if you will, with lots of attributes for each. Many of them are optional, but you can also extend them. So it's really flexible standard. And that's why I'm going to move towards the idea of community in a moment, because there are a lot of ways that one can use it to accomplish what they need. But in the bigger spirit of interoperability and scalability of designing applications that will really scale and be used in different places, I think there's this idea, it's important to think about consistency and sort of an understanding of how the best approach to get things done and to really minimize the variation in FHIR adoption as much as we can. So let's see. So in that spirit here of sort of FHIR being sort of the basic building blocks, again, the idea was to really simplify this complex version 3 standard into what I think was originally thought of as a handful of important elements like patient and encounters and conditions and labs, sort of basic things. Now I think it's close to 200, 190 or something resources. I think this is release 4. So we're up a little bit. So we've got a lot of these sort of data classes, and I'll show you just a peek, but they fall into a different set of categories, and you can sort of visualize them in a few different ways. And again, you can follow these links and just start clicking around and see it. But category, I think, is the first way to really think about these these sort of data classes. So you have the foundational things, which is just basic stuff about sort of the foundation of your data. What can your FHIR server, what can it do? What data do you have? Search functions, the terminology I mentioned, the code system and value set. I'll highlight here. I know this is tough to read. N is normative, which is the balloted. HL7 is a consensus development process. So these are balloted. Those are mature resources when you see them there. And they're so foundational, it shouldn't be a surprise that code system and value set are mature and considered foundational. Then we have sort of the base specification, which is like your patients, practitioners, sort of like your people, and then your entities, your healthcare organizations and services and departments. And then you can sort of move into, there's other entities, substances, or sort of medications fall under there, workflows and management. And then we have more clinical kinds of things. So I guess the medications sort of build from other base resources, but we can have a medication request, which is like an order. You can have a medication administration, which is more like an observation. You can have dispensing. And so some of the context is sort of built in here as unique and different resources. So you can kind of look at the maturity of this and what are your base things, which would be your foundation and your base elements, versus the things that are clinical, and then the ones that are being added on. So this is one way to look at it. And each of these resources can be represented. There's human narrative, but also in JSON, XML, and RDF turtle syntax. So that's one way, is to just sort of look at the resources by sort of category. You can also hop on and just look at them alphabetically, and there's a bunch. So it still takes a little bit, of time and thought, I think, to navigate these appropriately. But as you click on each one, you'll sort of get the the documentation and specification that you need. But there are some places where it's not always clear, oh, is this a communication or a task? And so that is where I think the community comes really in handy. And I hope I can encourage some folks to perhaps join or listen in on some of these calls. So in addition to alphabetical, you could kind of look at the standards by status. And again, I mentioned normative is what is the core spec. I mean, these are the things that are balloted. And I guess the idea is that much of this will eventually be balloted, but HL7 is a standard, it's a consensus organization. And so there's all kinds of rules about, you know, who can vote and when can vote and what you need to prepare to vote. And then when a vote goes through, you have to reconcile all the comments. And it's, you know, it's a consensus building process. So it takes a while, but you can sort of see the majority of these, the resources on FHIR are still for trial use. And there's some different levels of maturity within that category, but it's still a relatively new standard, I think, is maybe the take home from this. And then I think this is a helpful view too, again, thinking about community and who's using this. You look at these resources by work group. You can see, okay, biomedical research and regulation. So that's your pharma studies, your FDA is in there, your you know, observational research might be in there. So they sort of own and have taken responsibility for certain resources. They handle the governance of those. So if you want to make a change or have some sort of addition, even to the documentation, you would sort of work through these groups. Community-based collaborative care is one. There's this clinical decision support working group of HL7. They sort of own these different resources, and then they do a whole lot of other things too about how do you put them together into an implementation guide for a real task or project. Let's see. So let's just look at some common FHIR resources, and I'll also try and click over and to be a little more dynamic with this. But the first I mentioned is just the patient resource. And again, you can always get to your list of resources at hl7.org/FHIR, but you can, I've got the links to very specific ones. So this is like the most commonly used one, right? Anything that you're going to add or say about a patient or a patient's data is going to involve sort of specifics about the patient. And you can see like every resource will have sort of the content, the narrative, the examples, some detailed descriptions you can kind of see up top here. So the patient resource, really important. Medication request is just an example of one that's very important. Again, this is an order, but if you kind of want to see, well, what patients are on a certain medication, or, you know, you have to choose, is that because it's been ordered or because we've have a administration verification order, or is it just a statement, a report from somebody, either the medical record or the patient or the provider? Those are all sort of like different flavors of context that FHIR does and can represent. So that's important. And then I think for this group, really this observation, the resource observation is huge. That's all your vital signs are in there, all your laboratory data is in there, anything that you would sort of see like physical exam kinds of questions and answers types of things are observations that would be represented with this. So I think this is really an important class. And then as foundational, I'll just sort of highlight the code system is a resource about code system and the different value sets. And I'm going to just peek over. Let's see. I'm going to right now see, like, say, are you still seeing my, can you still see the screen? Are you seeing observations?
Yes.
Resource, good. Okay, I've got two screens. So just a quick look, and again, you could go here. You could just quickly look at this resource observation. It's owned by the Orders and Observations Work Group. I'm scared to click too much because I'll get lost on some path, but that's an entire group of interested members that come and go, and they develop projects and own resources. This is a mature, so this is normative. And let's see, in the security category, patient, let's see, the key thing I want to show. So it gives you sort of narrative of scope of usage. So the observation resource is used for all these things, all your clinical findings, imaging results, clinical assessment tools, social history, all that. And then this is what it looks like. I guess, you know, I encourage people to click around, but this really, to me, is like having a look at FHIR. So the content, you can look at structure, and then you can see the different representations of it. So an observation has all these attributes, and you can see how some are required and their cardinality can vary and is specified here. And look, everything from identifiers to triggers here, status. And look, this is an example of a value set. This is an HL7 value set. So the code can either be a registered, preliminary, final, or amended. And this is a required binding. So that's saying this here is a required value set. An HL7 organization hosts and maintains and curates a number of value sets. They also use code systems. And this is the other piece I wanted to just point out. So the codable concept. So remember, we're in the observation resource. So an observation has a code, right? So in that, it uses the resource codable concept. The type of observation, code or type, this binding here, it just says example. So it's actually, you can use FHIR and you don't have to use LOINC. You could use some other thing and share your data with FHIR. But if your lab data is not in LOINC and someone else's is, then you still have that issue of having to resolve that vocabulary and deal with that. I hope folks are interested in LOINC, and that may be another, I'm actually curious, I am going to just open this in a new tab. I think we will get to see this. This may be another idea for a talk, because again, questions and answers, vitals. I know Gabriel said that labs are important. LOINC is the named coding system for that, but organizations have sort of take their legacy and move it to LOINC, and that's done at different levels of sort of certainty and quality. But you can see here, I clicked on LOINC, and so LOINC is defined here. I guess they've moved it to a value set. Oh, this is value set I clicked on. So I'm not sure where I went to the LOINC here, but back to my resource here and code, my observation resource code. There we go, codable concept. So that really could be and probably should be LOINC as a coding system, but may not always be and doesn't have to be. So that's just one example of sort of the flexibility of FHIR and how the code systems sort of fit in these different attributes of FHIR within a resource, and that may or may not be required. And there's incredible flexibility here. You can also associate this with a certain healthcare event. You could have effective times around this observation. You have body sites associated with the observation. The body sites may be bound here. This is the observed body part. So you're noticing a rash on someone's arm. So you would use SNOMED CT as the code system for the anatomy. That's referenced here, and you can sort of click to SNOMED CT and get information on that as a registered code system. But notice that's just an example. It's not mandated. So that is where you've got that flexibility in the specification. And as you're building with it, then you add that sort of structure, that those constraints through profiles and then rules for a specific application within an implementation guide. So I hope that sort of is a little bit of a preview and maybe an enticement to just go check out these pages and look at it. I guess I didn't click the button where you can actually see the JSON representation of that in those of the resource and the attributes. You can see it in XML, and you can see it in RDF syntax as well. So I think I've heard that most people use JSON, most developers, even within the HL7 community, but you have those options, and HL7 is committed to maintaining those. So you can pull representations in any of those languages. Let's see. So again, if you think of these resources, so I said the building blocks, but small reusable structures that are defined to work with the FHIR RESTful API. And there's a set of elements defined in a strict hierarchy. And I gave you some little set of that. These are identified by a URL. There's a type within the FHIR specification of sort of those foundational and base and clinical elements, et cetera. And let's see, in version, if the contents change too much, then they can version the resources as well. But you can sort of get all this information from those HL7 and FHIR web pages. FHIR hosts lots of different data types, primitive and complex. I'll sort of just quickly go over those. important resources. I mentioned patient, then there's things bundle and list and composition and operation outcome, all kinds of things that you would use to sort of collect or retrieve and display lots of different types of information. Questionnaire is really important, and some of these basic ones about code systems, value sets, and provenance, audit trail, those kinds of things are really helpful, at least certainly from the institutional perspective. Again, we've got this sort of resource interest if you want to look at. I'll just, in the interest of time and the fact that I am not a programmer, again, just sort of mention quickly some of these other features that you can dig into more, but they really are important aspects of FHIR, this extensions, this ability. FHIR is sort of built with this 80-20 rule, and the idea is, again, just being practical and for implementers and not going down all these trails of these very specific cases. They sort of build on a principle of an 80-20 rule. So if 80% of systems would find a certain resource useful, then it will go in this FHIR spec. And if not, the idea is then you can make an extension for any of those edge cases or special things. FHIR resource IDs can be, there's a system that can be server specific, so you can reuse resources, but then in your FHIR server, you can sort of attach those and have logical IDs and all that. So there's some, a lot of thought in design around that, so that lots of institutions can have data in FHIR, but reuse these existing resources. And profiles are the way that you would say, in this case, LOINC is required, or we are using body site from SNOMED CT, and we're only using the body site class, or, I mean, there's different hierarchies within SNOMED, so you could get very specific there. And then implementation guides, which I want to show you quickly. Yeah, Gabriel, that's a great question. FHIR itself is open source. The code systems it uses, not necessarily, but I think governments are trying to do open things. And so SNOMED, for example, has licensing, but if you're within the US or another licensed country, it's free. So developers could use SNOMED, could use LOINC, RxNorm. I think the ONC is really trying to promote standard coding systems that are free. And I think globally as well, other countries have that same approach. So there probably are some of these, like, for example, Medra is licensed, and that is used very much in some of the FHIR implementation guides that are coming out of the BRNR, the Regulated Research Group, and Vulcan. And so I think different communities have to sort of deal with that. It's, again, pragmatics within a certain community. Maybe the paid or commercial code system is what is used and is what is most feasible. So that's sort of an ongoing tension in standards, actually, right? That that tension between sort of making them, funding them, right? And then and even marketing them for wide adoption versus making them truly open and accessible. So great question. I'll just say one more thing about implementation guides. I'll sort of back on these features. Profiles is one way to limit this super flexible resource for a certain community or use case, to say, we require this this code system, and we will not allow certain codes from other parts of the code system, or you can put lots of constraints. Implementation guides are also just kind of rules of what resources are going to be used, and includes sort of the working scenarios and whatnot. Here, if you go, there's an implementation guide registry here that's got, let's see, a couple hundred, 274. And so you might sort of follow this link on the registry and search under mobile even, and you'll see a whole bunch of things. They vary in quality and use and all that, but there's a lot of people building stuff with FHIR. And so I think before you build, or while you're building, like, look and see what others are doing and how they're using different resources and profiles, and is there something you can reuse. I think I will just sort of jump on. There's different examples of there's many in here. So just bear in mind that there is an actual registry of implementation guides, and sometimes the FHIR spec is ahead of implementers and regulators. And I think I'll just sort of go quickly. We're at FHIR 6 is sort of under development. FHIR version 5 is the latest of FHIR. the US core, I mentioned, is sort of on version 5, but what's legally required, I mean, version 5, I don't know when that would even be implemented. And 6 is still under development. So that's sort of moving along. And then if you look at the different vendors, like Epic supports, they list what they support. So you can actually just go to FHIR.epic.com and see what they support. And then, so they've got a lot of version release 4 resources, and then you could look under different systems. Cerner, for example, posts what they offer. So that would be sort of what you're limited in based on your organization. So those FHIR pages are great to look at, but in terms of what you can actually get to, you really need to sort of look within your organization or within your vendor. So you might just think about, as you're developing things, that lag between what's available, what you can expect to be in most DHRs versus what's in yours, and what is available via FHIR can kind of range. I'll just give a quick plug for some community stuff, because I know we've just got a few minutes left. There's a great chat, Zulip, chat.fhir.org. And you could just jump on, look at all these channels for every interest you have. You can subscribe and watch and post questions. And they actually say, if you post a question, please stay tuned, because you're going to get a flood of answers, and, you know, don't check back in a week, because there'll be other things going on as well. So I just hop on there. You don't have to be a member of HL7 to join any of these work groups or the Confluence site. The Confluence is their sort of interacting communications site. So you do require a password, a login and a password. But for this group in particular, if you go to the mobile health working group, seems particularly relevant. And I'll just pop in just to show you just a sense of, you know, you've got the co-chairs, the charter of the group, you know, what relationship they as a group interact with the healthcare records group, the clinical interoperability council, orders and observations. So some of this order stuff there, pharmacy. So all these networks and communications are in place. And when they go to their meetings, they have planned conversation with these different groups. And that's how you really prevent the siloization of FHIR. And it's a challenge. And this is one of the reasons why FHIR takes so long. Just for fun, I'll say that the next meeting is virtual. It's in January of 2025. And this is really early, but already, well, and for months, they've been sort of planning their schedule. So this is Tuesday, Wednesday, Thursday. They divide the days into quarters, but this is what they're talking about. So on Tuesday, they're going to talk about the consumer mobile health application foundational framework. And then there's obviously some projects around school health information and exchanging healthcare information with schools. And so the host is the EHR group, and the mobile health group is joining. And this is just kind of a template. This will get populated over the next month, but you can see personal health navigation and patient contributed data. These are both projects that I've been working on with the patient empowerment work group. So there's planned discussion to talk about those kinds of things. So you might at least look at these pages to see what projects are in the works. Yeah.
Rachel, could you put a link to that page in the chat?
Oh, yeah, absolutely. Let's see. I think, did I go? Let's see. Yeah, this is mobile health. And again, you might have to do, it might take a little work just to get a username and password, but I don't think it's too much. And then you could get on. So this is open collaboration, and organizations join and sort of vote. So Aaron, I don't know if we've ever got interest or funding. It would be, it might be interesting collectively if we did get a group together to sort of do a membership or coordinate which ballots we're going to, coordinate how we can involve and be involved in sort of the bigger picture. I will just sort of say that, the meeting notes, let's see. Okay, I showed that just to give you, you could just jump in any work group and sort of see every week they keep the notes there. So you can just go back over time and see what they're working on. They review the minutes. There's a motion to approve minutes. Robert's rules apply here. I mean, this is all about getting consensus and documenting it so that when a standard comes out as a normative standard, it's really done in such a way that one vendor didn't dominate it. It's tried to incorporate all opinions and make it as useful as possible. So you could just sort of get a sense of who attended. Here's a unique mobile health application identifier project. That seems like it might be relevant to some folks here. And framework for healthcare adoption of short message technologies. Not sure what that is exactly. Cardex is cardiovascular, and they're doing some hypertension management apps and things. So all kinds of really exciting stuff going on within the community that might give a sense of how to get started and make the most of this. Let's see, I'm almost done here. Patient empowerment group I mentioned, there's a paper on patient contributed data, which if you think there's patient generated data, but now as FHIR is becoming regular through 21st century cures, patients now have the right to get their data as a FHIR export from any health record. So now they're starting to pull that data together, and they can sort of mediate their participation in research, or they can have clinical data in the custody of a patient. So there's some interesting pieces here that you might think about for mobile apps, and they're not always getting the FHIR data necessarily from the health system. We can imagine different approaches to this. So keep an eye on that if that interests you. The FHIR accelerators are where communities have put a lot of resources into just developing and promoting FHIR. So the Argonaut is one, that's all your EHR vendors came there. Codex is cancer, Da Vinci is the insurance companies, and they've really pushed some demos. Vulcan is pharmaceutical, and FDA and NCI sort of moving things along. So those are pages to check out. They've got resources and people dedicated to sort of moving forward, building implementation guides that are useful. I won't have time to do this, but I hope you can watch. If nothing else, if you want to sort of see it in action, this 20-minute video, Josh Mandel, he works for Microsoft, but he's on the FHIR governance board and very familiar with it. He worked through Argonaut, so with all the EHR vendors, that group, the big players, to play with continuous glucose monitoring as someone who doesn't have diabetes, just as he just wanted to sort of get his data. And I think this feels very much up the alley of what I've heard comes from your group. It's a great 20-minute sort of demo on how he went down this journey and some of the challenges with displaying the data. And I think you'll hear some of the concepts that I mentioned today. You'll hear about resources, bindings, terminology bindings, groups, the visualization, all kinds of things there. So it's actually a fun demo, and you can actually grab it from that QR code, I think. Let's see. Okay. Yeah, I'll probably just stop. I think, let me just stop and see if we've got 10 minutes for questions. I just had a couple of ideas that I thought, based on some of what I was looking at your MDEN group on terms of if we got clear on this, maybe to Aaron's earlier point about we could sort of decide what resources are the most important from our vendors or from our health system that we could come together on. So I think I'll just pause there for questions, and just know that I've got a bunch of resources for future learning here, videos, textbooks, all kinds of things that are really just hands-on. The Happy FHIR server is one that people use, and the Epic user web we can sort of log on to too, and the Michigan Medicine version, and see what we've got in terms of sandboxes there. I'll end on this slide because I'm hoping that you'll take a minute to just answer 2 questions about whether this was useful, or if you have other questions that we don't get a chance to answer now. So I'll leave either that link or QR code up. And then, yeah, sorry, I talked a little more than I wanted, but we still have about 8 minutes for questions and discussion if people want to.